I think Dr. Chinnaswamy, who is a master right now, is going to clear most of our doubts.
Posterior VS. So how much you can really understand this, I'll leave it to you. Now I'll go on to morphology of the interventricular septum. My professor used to say, if you can understand the interventricular septum of the heart, the morphology, you can understand the whole of the heart. I hope it's audible. Yeah, thank you. You can understand the whole of the heart. ఏమైంది ఇక్కడ ఇచ్చేస్తానులే, no problem, don't worry. So the ventricular septal defect can have different phenotypes. To be able to make a clear distinction between these phenotypes is essential for a correct diagnosis and medical and surgical management. The problem resides in different systems nomenclature that continues to create issues in communication between the physicians. In the past, indeed, since 1980s until now, two different approaches emerged for classification. One based on the geography of the defect, looking at the posterior-inferior part of the defect. This is important for the surgeon because the risk of the injury to the conduction tissue if such a fibrous component exists. The difference between these two approaches still induce confusion in classification and nomenclature of ventricular septal defects. The geographic approach seems to be more suited to our daily clinical practice. So to specify the phenotype of the VSD with its exact location within the ventricular septum according to the geographic approach, and then borders of the VSD are carefully described, as well as the relationship between the atrioventricular valves and the arterial valves. So that is to say, identify the VSD with respect to the location within the interventricular septum, and then define the borders in relation with the atrioventricular valves and the arterial valves, so that you can exactly localize what the borders are and where exactly the location is, what are the structures that are related to, and you need to take care while performing the operation. So basically you have the two parts of the interventricular septum, that is the membranous septum and the muscular septum. Membranous, of course, has two parts. It has atrioventricular part. Now you can see only here the interventricular part. It has actually atrioventricular part as well. So to the atrioventricular part, you have the muscular septum that actually converges onto the membranous septum. In the muscular part, you have inlet and the trabecular and outlet septum. That is the septum. Whereas in trabecular, again you can divide it into anterior, posterior, and apical and mid-septal. So these are actually the parts of the septum. You need to be clear to localize where exactly the VSD is. So this illustration will actually tell you where exactly the location of the VSD and what actually these borders are. Based on this, the VSDs are classified into central perimembranous VSDs. The VSDs that are located in the membranous portion of the septum are called membranous VSDs. Since they extend it to the either to inlet or to the trabecular or to outlet, they are called perimembranous. It extends outside the membranous septum. So that's why they are called perimembranous. See here, you have actually this membranous septum here, which has an extension towards inlet called perimembranous VSD with inlet extension. And you have the extension to trabecular, you have trabecular extension. You have extension outlet and you have perimembranous outlet extension. So perimembranous VSDs can be, it's rare to find actually the central perimembranous VSDs confined only to the membranous septum. In fact, they invariably have extension to all these things. And then you have in the inlet septum, the inlet septum is defined by the septal leaflet tracheus valve till the attachment of the papillary muscle. That what is the inlet septum. So any VSD in this location is called inlet VSD. It can be inlet bordered by the septal leaflet tracheus valve. It can be inlet muscular, completely muscular, and then you have trabecular VSDs, and then you have outlet VSDs. So in the trabecular VSDs, there are different types, which I'll come to that later. In the outlet VSDs, actually, you see here the G is actually the subarterial or the juxtaarterial. Here, the pulmonary valve or the aortic valve form the fibrous margin, and whereas the F is completely muscular within the conal septum. So these are all the various VSDs. You can see here the most common is perimembranous, and least common is actually the inlet VSDs, and trabecular 5 to 20 and 5 to 7 is outlet VSDs. So since to avoid the confusion, the classification of VSDs, the Society of Surgeons used the hybrid system, classification system involving the borders and the geography for its international database, incorporating commonly used synonyms. We are all aware, as cardiac surgeons and the cardiac residents, so many names have been used for the same VSD. Cardiologists will tell you, posterior muscular. In fact, it will be actually inlet muscular. So there are a lot of confusion regarding where exactly. You can see here the type 1 to 4 classification, hybrid classification. You can see how many names are actually there in each of this. You have in type 1 subarterial VSD, supracrystal, conal, septal, outlets, infundibular. You have in type 2 perimembranous, type 3 is AV canal, and type 4 is muscular. So to understand this, let me go back to the previous slide. See, so it starts with outlet defects, class type 1, and then comes to perimembranous defect type 2, and then comes to inlet defect type 3, and trabecular. So this makes it very clear when you when this is the geographic location. Then you have to go into the borders. Now coming to fully appreciate this, you need to know the normal ventricular septal anatomy. So in order to fully appreciate the geography and the borders of the VSD, one must understand the landmarks of the normal ventricular septum from the RV perspective. As I mentioned earlier, membranous septum, that's the membranous septum there, that's the interventricular part, that's the atrioventricular part. So here actually the perimembranous defect, you can see here the AV node, which is at the apex of the triangle of Koch. It goes, the bundle actually travels along the posterior inferior border. So that is the medial septal pupillar muscle attached to the posterior inferior limb of the trabecular septum marginalis. So that is the septal band, which actually comes from the from the apex of the right ventricle, traverses all the way up to the base of the right ventricle, dividing into the anterosuperior limb and the posterior inferior limb. And here to the posterior inferior limb is what is attached the medial septal pupillar muscle, which is a landmark that tells you the course of the the bundle. And then between the two limbs of these two is the conal septum. So, and then you have the moderator band here, to which the anterior papillary muscle is attached. The inlet septum is actually from the septal leaflet tracheus valve to the septal papillary muscle. This is what is the inlet septum, that is the outlet septum, that is the trabecular septum, that is the membranous. So you need to understand the various part of the septum and the various landmarks of the on the right ventricular aspect of the interventricular septum. So the medial papillary muscle, which is usually located on the posterior inferior limb of the septal band, and supports the anteroseptal commissure. This papillary muscle gives rise to chordae, which supports the anteroseptal commissure. So, and then you have the subpulmonary sleeve, okay, separating. This is what separates the pulmonary valve from the tracheal valve. All these the morphology structures can vary significantly even in normal hearts. And an important structure in the setting of the outlet septum is the outlet, outlets defects is the outlet septum. That is the conal septum, which I showed you. This diagram will show you the right ventricular aspect of the ventricular septum in the normal heart. So the muscular bands on the right ventricular are, as I told you earlier, that is the ventricular infundibular fold, and to which there is a parietal band usually which arises from the conal septum attached to it, and the conal septum is between these two limbs of the trabecular septum originalis. That's also called the outlet septum. So, and then as I explained to you here, the moderator band, you can see here the pathologic specimen here, that's a moderator band with the anterior papillary muscle, that is the trabecular septum originalis with the anterosuperior extension, that's the limb, and the posterior inferior limb, that is the septal papillary muscle is attached to the anteroseptal commissure, that's the conal septum, that is actually the VI fold, and that's the parietal band. So this is the anatomy which you need to understand in order to define the borders. So based on this hybrid classification, they are classified as type 1 outlet defects. They can be, perimembranous VSD. Perimembranous VSD with outlet extension can also be included in the outlet VSDs. And they can be outlet muscular and juxtaarterial. Outlet muscular, completely muscular margins, whereas the juxtaarterial will be, found by the bordered by the either the pulmonary valve or the aortic valve or both. So opens into the outlet component of right ventricle between the limbs of the septal band, behind or near the anterior leaflet of the tracheal valve. It's actually anterior. You can see here the anterior leaflet here. See that where it is. The outlet VSD is actually behind and away, from the anterior leaflet. Whereas the perimembranous VSD is actually here at the anteroseptal commissure. You can see here that is the posterior limb, posterior inferior limb. That is, so it is actually away from the anteroseptal commissure. There can be malalignment of the conal septum. In this may or may not be malalignment in these situations. Outlet perimembranous defect. That is the C. See outlet. That is the C. Outlet. There is a perimembranous extension into outlet. That is called outlet extension. Defect and juxtaarterial may have the posterior inferior margin as the fibrous margin. These are the wherein the conduction system can come along its posterior inferior margin, can be at the risk of injury when you are closing the ventricular septal defect. Whereas in outlet muscular defects and juxtaarterial, sometimes juxtaarterial can have muscular defect. The septum is actually the conal, the bundle is quite away, so the risk of injury is less likely. This is one of the diagram actually showing the doubly committed VSD. Doubly committed VSD, you can see the pulmonary valve there, aortic valve here, and between the two limbs, and there is a good muscular margin there, and the conduction, that is the septal papillary muscle, the medial papillary muscle. So it's actually the risk of injury is quite less because there is a tissue separating, actually muscle bundle separating the aortic valve from the tracheal valve. So this protects actually the bundle. You can see here the anatomic specimen also, trabecular septum marginalized with anterior superior and posterior inferior limb, and that is what is the ventricular inferior fold and the posterior inferior limb. That's actually protecting the conduction system. So in perimembranous defects, so you can see here the perimembranous defect is actually related to the anteroseptal commissure, that is to the medial papillary muscle, and you have there the posterior limb, posterior inferior limb. So it is, this is at the risk of actually the bundle is very close to posterior inferior margin, is at the risk of injury. That's why defining the location in the septum and defining the border is extremely important to avoid to take care injury to the bundle. So and it is then the conduction system is near the posterior inferior margin of the defect. See, this is another diagrammatic diagram which actually illustration that shows this as a perimembranous VSD with an inlet extension. You can see here it is undercover of the septal leaflet or tracheal valve. So there is a small portion of the membranous septum. So perimembranous with inlet extension. You can see here at the posterior inferior margin you have a bundle which is at the risk of injury. When you are closing the VSD. So that is the posterior inferior limb of the trabecular septum marginalis. And this is actually a small perimembranous VSD, and it is at the anteroseptal commissure. So you can see here how the bundle traverses along its posterior inferior margin. This it can be sometimes rarely can be located centrally only to the membranous portion. But most of the time perimembranous VSDs have an extension to all the three components. This is actually perimembranous VSD with an inlet extension. You can see here the node is displaced. Node is displaced quite posteriorly and it has a long course along its posterior inferior margin. So you need to identify where the location, exact borders of this in order to close. That's the pathological specimen. Okay, that is showing the inlet VSD defect opening right ventricular inflow below the anteroseptal left tracheal valve, and the defect extends along and mostly covered by the septal leaf trachea valve. This will be under cover of the septal leaf trachea valve. Unlike in patients with perimembranous VSD with outlet extension, that will be covered partly by the anterior leaf trachea valve. And you have here the outlet perimembranous VSD. So in this case, unlike in the previous case, you can see here it is right extending up to the tricuspid and aortic area of fibrous continuity. So it has an extension right up to the tricuspid valve. These are in these patients, though it is outlet VSD, since it has extension towards the perimembranous area, and there is no tissue separating the tricuspid valve from the aortic valve. Obviously, the bundle is at the risk of injury. So you need to make a note of exactly the borders and define it. So before you try to close it, otherwise you would land up in having blocks. So this is one of the operative photograph. Actually, it's a perimembranous VSD. You can see here the LA is vented through this. Actually, it is closed. That is the anterior leaflet, and the septal, that's the anteroseptal commissure. And that's exactly where is the right fibrous trigone. And here, actually, that is the membranous septum. This is perimembranous with somewhat extension into the trabecular portion. It has a good margins. It also had a subaortic membrane there. We had to excise the subaortic membrane and have to close. It has a good, fibrous margins. So then comes to inlet VSDs. Inlet VSDs can be inlet defects exclusively in the inlet close to the tricuspid valve, bordered by the annulus of the tricuspid valve. They can be inlet muscular, and they can have inlet VSD with perimembranous extension. So there can be AV canal type. In these cases, especially inlet VSDs, AV canal type, where it is bordered by posteriorly by the septal leaf tricuspid valve, there can be septal malalignment. The atrial and the ventricular septal malalignment, number one. Number two, there can be straddling or overriding of the tricuspid valve. More commonly, but sometimes even the mitral also can override. So it opens in the inlet component of the right ventricle, extends beyond the septal leaflet of the tricuspid valve, and below the anteroseptal commissure, and also below the posterior limb of the septal band and the papillary muscle of the conus, with or without malalignment between the atrial septum and the ventricular septum. So it as I told you, it has an inlet extension, perimembranous extension. So the bundle is at the risk of injury because it is at the posterior inferior border. So inlet muscular, whereas inlet muscular VSD, the bundle is at actually, I have a diagram, I'll show you. So that's actually the inlet muscular. You see here where the bundle courses. It will be bundle courses quite far away, superiorly and anteriorly. So it is less risk of injury. Here that solely it is formed all the borders. Even at the in the region of the septal tricuspid valve, there is a muscle actually forming the border. So it's less likely that the bundle gets injured in these cases. That is the specimen, pathologic specimen there. And here you can see the triangle of Koch. That's where the node is, and the bundle traverses quite far away. So very less likely that the bundle gets injured in this region. So this is the AV canal type which I was talking about. You can see that is actually the node is so much so displaced, so posteriorly there can be actually two nodes, one non-functional node here and an abnormal node here at towards the crus caudalis, and it has a long course of the bundle. It's very these are the high risk cases for bundle injury when you are closing the VSD. These are the cases where there can be septal malalignment and also the overriding or straddling of the valve. This is the operative photograph. Actually, you can see there are two VSDs there. One VSD here. It is actually perimembranous VSD, and you have another VSD. It's actually inlet VSD, muscular. You can see margin there. It is extending all the way down into the the trabecular septum. There are two VSDs there. See, that is the right fibrous trigone, and that is the coronary sinus. And we expect the bundle to be here, and the node to be here, and bundle to travel along this strip of muscle. So when you are closing that kind of VSD, it is better to avoid to separately closing. Better to take a single large patch and close it, so that you can avoid the injury to the bundle. And coming to type 4 VSDs, that is the trabecular muscular VSD, usually they are in the muscular portion septum. All borders are found by the muscular septum. So the bundle is nowhere near, so very less likely the bundle gets injured in these patients. But these can be in multiple locations. They can be apical, anterior, mid-septal and posterior. These are the 4 locations. It can be in trabecular septum. So when you are actually saying muscular VSD, you actually localize exactly where they are. Or they are anterior, or they are apex, or they are mid-septal. Mid-septal is actually above the moderator band, and posterior septal is above the posterior to the moderator band. So that's one other type is the switches type where multiple defects, which involves all the components of the trabecular septum. So since it is switched a lot of holes, a lot of defects in this, it's more often not possible to close all the defects. In such cases, you may have to go for pulmonary artery banding instead of primary closure of all the defects. And when you do a pulmonary artery banding, and many of the small defects will close down eventually, and what remains later on with some of the large defects, 1 or 2, which can be comfortably closed at a later date, maybe at 1, 2 or 3 years of age. Another defect is the Gerbeau defect, as I was telling you about atrioventricular septum. Since the tracheus valve is at a lower level than the mitral valve, there is a portion of the septum called atrioventricular septum. So any defect in this portion would result in left ventricular to right atrial shunt. So that's called Gerbeau defect or Gerbeau shunt. So what are the changes to the conducting system in various VSDs? In membranous VSD, as I showed you earlier, there is migration of the AV node posteriorly towards the crus cordis, crux of the heart. So the east bundle courses along the posterior inferior margin, though it courses, but still it's actually away. Since the node is displaced posteriorly, there is less likely that the bundle gets injured even in perimerious VSDs with inlet extension. So the location of the conducting system in various VSDs, for example, in membranous VSDs, as I mentioned earlier, in the posterior inferior. Muscular, I mentioned earlier, it is nowhere near, it's actually quite far away because it's anterosuperior. And whereas in AV canal, I showed you the one of the image photo wherein it has a long course all along its posterior inferior. It's very likely that they get injury to the bundle, and the incidence of bundle block is very high in such cases. So to summarize, the proposed classification of the VSDs as outlet VSDs based on hybrid classification by STS. So type 1, type 2 central premonerous, type 3 inlet, and type 4 trabecular VSD using the geographic coordinate. First use the geographic to identify where exactly is the location VSD as the starting point of the classification, highlighting the importance of describing its borders, to then describe the borders one by one so that it will give you a clear picture what are all the structures related to the ventricular septal defects. So that will give us an idea surgically to plan for on the table, either preoperatively or even on table, to plan to how to close the VSD, thereby avoiding injury to the important surrounding structures. In the hearts with concordant connection, central premonerous VSDs are usually adjacent to the area of fibrous continuity between the septal leaflet of the tracheus valve and the aortic valve, and they are located below and behind the posterior limb of the septal band, as I showed you in the diagrams. Inlet VSDs open into the right ventricular inlet below the posterior limb of the posterior inferior limb of the trabecular septum marginalis and the medial papillary muscle, whereas the outlet defects are in the right ventricular outlets between the two limbs of this septal band. Inlet defects are associated with the malalignment of the atrial septum or the ventricular septum, typically straddling of the tracheus valve. Many times you might come across straddling. In contrast, outlet VSDs are often associated with malalignment of the muscular or the fibrous outlet septum relative to the limbs of the septal band. Sometimes even in outlet septum also there can be malalignment. In fact, you can see aortic pulmonary valve actually somewhat arising from the left ventricle. So recently we had a case, it was nearly arising 30% from the left ventricle. Normal related gaiters. There can be septal malalignment resulting in partly the pulmonary valve arising from the left ventricle. So the conduction pathway is located along the posterior inferior border of all pulmonary defects and juxta-arterial defects with a fibrous inferior margin. In juxta-arterial, there has to be a posterior inferior fibrous margin. That means there is no septum separating the aortic valve from the tricuspid valve. So that conduction bundle actually comes very close to the margin, whereas it is remote from the inferior border of all other defects. So the trabecular muscular defects are embedded within the muscular septum and can occupy any of the geographic components. All VSDs can occur in isolation or as a confluence of two or more types, as I showed you earlier, and as the integral part of any other. They can be integral part, as so far I described about isolated ventricular septal defects, but they are also the integral components of many other congenital diseases. For example, most common tetralogy FLO, okay, or DORV or transpositions or something. So I think if time permits, I have 3 more slides. I'll conclude with indications. So finally, coming to indications. So all are class 1 indications. Small VSDs, that means no asymptomatic, normal PA pressure, normal left heart chambers, that means no chamber dilatation, no cusp prolapse, means aortic cusp prolapse. They require only annual follow-up till the age of 10 years of age. Guidelines for Indian guidelines, they are called Indian guidelines for indications for congenital heart diseases, intervention or either catheter interventions or surgical interventions for congenital diseases. So closure is indicated if one single episode of infective endocarditis is there, closure is indicated, or they develop any cusp prolapse would result in aortic regurgitation is the indication even in small VSDs, or sometimes they tend to develop right ventricular outflow tract obstruction. So all these things, an episode of infective endocarditis or a cusp prolapse, which is the cause for the aortic valve regurgitation, or the development of any right ventricular outflow traction, all these are indications for intervention in small VSDs. Whereas in moderate VSDs, if they are asymptomatic, that means the pulmonary artery pressure is normal with left heart dilatation, they have to be closely followed up and may be planned by age of 2 to 5 years of age, plan for closure of the ventricular septal. We intervened as early as possible. We do have intervened as early as 2 months and irrespective of the weight. So any baby with heart failure, which is we are not able to control the heart failure despite maximum medical management, sometimes they might go on ventilator as well, and those who have poor growth, better to plan early intervention. So whereas those who have a controlled heart failure, then you can decide about intervention electively. Maybe ideal would be about 4 to 5 months or 6 months of age would be ideal. So VSD with aortic cusp prolapse, any VSD with the cusp prolapse which is directly the cause for the regurgitation, anything more than trivial is surgical closure of the VSD is indicated in order to prevent further damage to the aortic valve. Thereby the more the aortic regurgitation, less likely that the valve can be less likely that there can be one-time intervention. They can come for re-interventions. Better to intervene when it's trivial or less than mild, so that you can solve the problem once for all, so that they don't need to have multiple interventions. Anyway, anyone with a severe aortic regurgitation would rather, though you might repair it, they definitely come for re-repairs or replacement at a later date. So better to prevent damage to the valve by intervening early. So contraindication, of course, is any irreversible pulmonary vascular disease is a contraindication. So the method of closure, of course, is the surgery. The conventional patch closure is done, primarily surgical closure. So that is by closing with the patch. And the pulmonary artery banding, as I told you earlier, those with multiple VSDs like Swiss defects, those with inaccessible VSDs, and those who are contraindications of cardiopulmonary bypass. Suppose there you have comorbid issues like infection, on ventilator, there is a possibility that you will not be able to do a complete correction, or the risk of CPB because of development of sepsis. You can plan a closed procedure, do a band and get him off ventilator, and then plan at a later date for the closure of the VSD. Device closure is indicated when there is a child is more than 8 years of age, when there is a suitable indication with a good muscular margins all around. And not only device, in the cath lab. There can be per ventricular device also can be done in the OT as well. Per ventricular through the right ventricle, under the transesophageal echocardiographic guidance, when you do a partial sternotomy, lower sternotomy, then access the right, VSD through the ventricle by passing a needle and a guide wire and to across the VSD, negotiate left side of the heart, and then under the TE guidance, you can place the device to close the defect. This is quite easy in patient with mid-muscular defects. We do have done a few of these perventricular device closures. So follow-up is recommended ECG, clinical ECG echo in the first year. If there are no other issues, no residual defects, no pulmonary hypertension, no other issues, then actually speaking, after 1 to 2 years, we don't need any follow-ups. Unless they develop any, you need to of course educate them for any onset of new symptoms or any palpitations, things like that, or any residual defects are there. We need to advise them early. You need regular follow-ups. Otherwise, you don't need to advise any follow-ups after 1 to 2 years of procedure. So, whereas in patients with device closure, antiplatelet agents are advised for a duration of 6 months in order to prevent thromboembolism. Infective endocarditis prophylaxis, both in surgical and device closure, is indicated for about 6 months. And of course, you need to explain to them about good, oral hygiene, maintaining good oral hygiene in order to prevent any infections. So, thank you.
Thank you for your valuable insights, sir.